Dr. Sainath Raman is a Senior Research Fellow at the Child Health Research Centre of Queensland. He's an early career researcher and paediatric intensive care specialist. Dr. Raman's research interests span both preclinical and human clinical trials with a focus on sepsis and inflammation. He's the Deputy Medical Lead for the Queensland Paediatric Sepsis Program and leads the sepsis and fluid theme within the Paediatric Critical Care Research Group, the Child Health Research Centre at University of Queensland. And he's going to speak to us today on antimicrobial optimisation in paediatric patients. Thank you.
Thanks, Susie. I had forgotten all about neonatology. That was a refresher, and thank you very much. That was a very nice talk. I quite enjoyed it. So first of all, thank you, Susie and Jason, for inviting me to speak today. Big disclaimer, I am not a pharmacist. I don't have as much expertise as my senior colleagues who are sitting there watching me, making sure that I say the right things. So feel free to correct me as I go. So my talk was named that, and I took the liberty to veer off scale quite a lot. So you will find that while I focus on things that I witness every day across on the unit, I'm hoping that we can also discuss things that we can work towards. So this was the first one I looked at. So the dosing in pediatric practice is very varied, and you will find that just across the different books that are used for pediatric dosing, each one is different. And the one in the red box is what we use in our unit. And we are different too, just because we can be. So it pretty much shows that we don't know what we are doing. It's a good start, because that only means that we can get better. So the next thing I found is this, where if we were to dose them subtherapeutic, we absolutely change their flora in their respiratory tract. And I won't go into the details of the genus and things. What they are showing is that between the two groups, very small study, sure, but between the two groups, the pattern of the respiratory flora are different. And maybe if we were to follow this up, their outcomes are different. So it's incumbent on us to get the dosing right and dose our children appropriately. So how do we dose pediatrics? And I thank Quinn for this beautiful slide. So this, we use allometric scaling. Sure, we know what the dose is in an adult patient. It's 1 vial of this or 1 vial of that. So we just choose to change that towards a pediatric dosing, sometimes weight-based, sometimes age-based, acyclovir, for example, is body surface area based. But we know that children are different. Children are different in their maturity of metabolic capacity, different in the way the fluid is around their body, different in the way their renal system works, different in the way their gastrointestinal function works. And so knowing the differences in pretty much every sphere of drug metabolism, we still seem to not be able to appropriately optimize it. And this is a pediatric, normal, healthy pediatric patient, okay? And now bring it into a critically ill child, and everything changes, because nothing that you believe is normal in kids is the same in my practice on intensive care. And so I want to perhaps go through a bit more detail about the various nuances that I see in our practice. The first of which is augmented renal clearance. And Fran briefly mentioned and alluded to this, and there's a lot in the literature around augmented renal clearance. But first point, we don't know how to define augmented renal clearance. And therefore, the prevalence changes between being 8% to 80%. We don't know how to measure GFR in kids. We don't know whether there is pediatric definitions or should be the same as adult definitions. And we don't know whether that changes on day 1 to day 4. My children, the kids that come to us on average, stay with us for about 3 to 4 days, median length of stay. And so the sick septic kid who is got multi-organ dysfunction on day 1, perhaps their ARC is very different to when it's day 4 as they're recovering. But do I change the antibiotic dose as they recover? Of course not. That would be too complicated. And my pediatric practice is from 0 days to 16 years, but the dosing is weight-based. And I do not focus on ARC as I look at these children. So there are numerous reasons why we don't know what we are doing, and therefore we need to focus more on how we can optimize this. One potential way of doing it could be how the KDIGO criteria is used. So KDIGO criteria is how we define acute kidney injury in adults as well as in children. And you would then see a change from baseline. And these researchers, I put these plots simply because they were beautiful, but also because they illustrate a point. They looked at 100,000 children who came into hospitals in China, and they looked at 2 points where their creatinine was measured. And they found that there is an inflection point from a change in baseline creatinine of 20 from baseline, or a 30% increase from baseline. And if those metrics were met, they call it PROC, or a new definition of AKI. And they were able to find that they correlate very well with the KDIGO criteria. So if you were to look at the 2 definitions that I present, they have similarities, which is change from baseline. So perhaps what we need to do is to look at a relative increase from baseline of creatinine clearance. And that may be the way to look at ARC in pediatric population. The second is the group on ECMO. I put these pictures not because they are pretty, but because these are the pictures, these are the circuits and the membrane oxygenators that we use in 1 unit in Queensland, in Brisbane. And to imagine across the world, the number of circuits that people use. So we have a 3/8 circuit, a 1/4" circuit. We have 2 oxygenators, we have 3 pumps. This is all just 1 unit. So there's significant variability in practice in just the kit. And to then expect us to understand how a drug gets adsorbed, perhaps, or metabolized, or leaches into the system, into the kit, is incredibly difficult. And the pharmacist in me says you should look at, there isn't much of it, by the way. So look at volume of distribution. And volume of distribution can be, so I will go through bits of it. So the pathophysiology section. So a septic kit comes in, gets placed on ECMO. They get all the blood products. They're septic, and therefore their circuit gets changed. So I lose a whole circuit, a whole blood volume. And if you look at the neonates, that's nearly twice their blood volume gone with all the drugs, sedatives. The kid wakes up. Antibiotics, I don't check, so it's okay. So how do I expect that the child will get better when I have numerous of these interactions that we are not focusing on? And then bring in the clearance aspect of it. So in our unit, our practice was that we would use SCUF, which is slow continuous ultrafiltration. So and a patient goes on ECMO, automatically we place them on SCUF in addition to the ECMO circuit. And SCUF is brilliant to take out fluid, but it might very well be taking out other drugs. And sometimes, occasionally, we might choose to place them on dialysis whilst on the circuit. So that's just renal support. And again, you overlay that with pretty much everything else that's going on with this child. No wonder we don't get our numbers right. And thank you, Quinn, for putting this together for me. This is a child who was on ECMO with us for, as you see, 36 days. And the blue dots are the number of dosing changes. Any change is seen as a dip or a change. So there are 16, I counted them, and 35 days. So 1 into every 2 days, we are changing the dose. So the child goes on ECMO on about 10, 12 days, and it takes us nearly 20 further days before we get our dosing right, which was actually, we never got our dosing right. I can say this because I was part of the team, just make sure I don't mention the hospital, but we were targeting 4 to 5. We never got it. I'll leave it at that. I won't go into the clinical details of the child, But this is us noticing, and this is us being proactive. Our pharmacists, our senior pharmacists who are doing an amazing job, say to us, look, this is going to happen. Can you please focus on this? Let's do levels. But still, this is happening. So the only way forward for our children in these two populations has to be therapeutic drug monitoring. That's the only way I can think of, which will at least get us to safety and perhaps limit toxicity. And then the cardiac bypass kids who come back to us. This is a seminal paper, so I place it here, but there are numerous other papers that have documented that the cardiac index drops at around 9 to 12 hours after they come off bypass. And the renal function changes post bypass. It's all documented. This is 1995, so this is nearly 25 years, 27 years ago. And do we change antibiotic dosing post bypass? No, we don't. The fluid status changes. We know all this, but of course, we just give them the one dose. The peri-op antibiotics is only 3 doses. And if they become sick, they get 1 dose, weight-based. And this paper, which is relatively recent, I would call it, 5 years ago, looks at 56 children, and they find, as one would expect, that if you have been on bypass for longer, or you have a preserved renal function, then your probability of target attainment is lower. It fits, but this is the first step towards where we want to get to, which is to precisely dose. I'm already talking about the next talk, aren't I? So the suggestions or the potential thoughts I had around this was you would optimally dose by regime, and that paper that I briefly mentioned to have tried different dosing regimes, and they've model simulated it, and they've suggested some doses which are different to what they are now. And then of course, TDM comes in again, so therapeutic drug monitoring in this population is relevant. CRRT, I'll keep it brief in this section. This was just our group of patients, 4 years worth, about 650 children. The incidence of AKI was about 17%. And if you were to compare it to the other metrics that have been reported, it's about 5%. So higher incidence of AKI in the cardiac population. So quite a lot of them were 80% of them post-cardiac surgery. A big caveat to note, those that come back from theater after having had bypass gets muffed as well, which is modified ultrafiltration. And so their creatinine is actually normal when they come back, which is not true, obviously. So they have a renal dysfunction in addition to that. And their death rate is 2.7%. And to give you a benchmark, normal PQ crude mortality is about 2.5%. In the cardiac group, it's about 1%. So already you have a 3 times increase in the AKI population. And this paper, which was recently published, notes that you have so many variations in the circuits that are used that, of course, you will have variable antibiotic concentration. And in this one, this is a very small study, just 9 children, 53 samples. But the first time around, they look at meropenem dosing, and they suggest perhaps different dosing might achieve better results. So absolutely, a lot of work needs to be done here. But until then, I suspect therapeutic drug monitoring is the way forward. And so the way I think about dosing now in my PQ is to look at the individual child, think of the numerous aspects that I've highlighted and several others that others point out to me, and use something like an organ dysfunction. This was recently published. It's called PODIUM, which is a pediatric organ dysfunction scoring system that has been defined as a consensus. And so look at the organ dysfunction, perhaps modify the dosing according to the organ dysfunction, and wait for more evidence for each of the systems. And then, of course, look at the pathogen and the MIC. But it will have to be done with therapeutic drug monitoring. I'm not going to go into detail about therapeutic drug monitoring. That's a talk in itself, and lots of others have given these talks. And this is a slide I borrowed of Quinn's. So you could have nomograms, you could have linear regression, but of course you can have model-informed precision dosing. This is the current state of play for TDM. And in our unit, we certainly use it for vancomycin. More recently, as part of a research study, we're using it for beta-lactams too. And we are finding certainly in our practice that we are achieving better targets. We are testing ourselves in this where we have a wager as to whether we can get the dose right and the target concentration right, and 99% of the time, I am not right. So this is a paper from Switzerland, which they have been doing it for 2 decades. So it is possible. It is happening out there. And TDM certainly helps us with numerous ways. Of course, dose reduction occasionally, but what we are finding is just not changing the dose is also good in itself. Then at least it reassures me as a clinician that the child is not getting better despite the best of our efforts. That's okay, but not delivering the right therapy is suboptimal at the best of times. But TDM may not be the answer all the time. This adult study recently demonstrated no benefit in terms of SOFA score, or so maybe it's got its caveats, maybe it needs to be nuanced, and that's probably where we are now. And I'll leave this because this will lead you to the next talk. Thank you very much.
Thank you very much, Sai. That's an excellent presentation. Now, I'm noticing there's some questions coming up in the Q&A, but I think we might move on into our final speaker.